diabetes. There's so much information out there that it can sometimes be challenging to find the information you need. Healthpedia.tv is here to make things less complicated for you. Let's start at the beginning. History. Diabetes was one of the first diseases described, with an Egyptian manuscript from c. 1500 BCE mentioning 2 great emptying of the urine. The Ebers Papyrus recommends a drink to take in such cases. The first described cases are believed to have been type 1 diabetes. Indian physicians around the same time identified the disease and classified it as madhumeha or honey urine, noting the urine would attract ants. The term diabetes or to pass through was first used in 230 BCE by the Greek Apollonius of Memphis. The disease was considered rare during the time of the Roman Empire, with Galen commenting he had only seen 2 cases during his career. This is possibly due to the diet and lifestyle of the ancients, or because the clinical symptoms were observed during the advanced stage of the disease. Galen named the disease diarrhea of the urine, diarrhea urinosa. The earliest surviving work with a detailed reference to diabetes is that of Aretius of Cappadocia II or early 3rd century CE. He described the symptoms and the course of the disease, which he attributed to the moisture and coldness, reflecting the pneumatic school beliefs. He hypothesized a correlation between diabetes and other diseases, and he discussed differential diagnosis from the snakebite, which also provokes excessive thirst. His work remained unknown in the West until 1552 when the first Latin edition was published in Venice. 2 types of diabetes were identified as different conditions for the first time by the Indian physicians Sushruta and Charaka in 400 to 500 CE. One type was associated with youth, and another type with being overweight. Effective treatment was not developed until the early 20th century when Canadians Frederick Banting and Charles Herbert Best isolated and purified insulin in 1921 and 1922. This was followed by the development of the long-acting insulin NPH in the 1940s. Etymology. The word diabetes comes from Latin diabetes, which in turn comes from ancient Greek diabetes, which means a passer through, a siphon. Ancient Greek physician Aretius of Cappadocia FL. 1st century CE used that word, with the intended meaning excessive discharge of urine, as the name for the disease. Ultimately, the word comes from Greek diabene, meaning to pass through, which is composed of dia, meaning through, and bene, meaning to go. The word diabetes is first recorded in English in Diabete, in a medical text written around 1425. Mellitus comes from the classical Latin word mellitus, meaning melite, like sweetened with honey, honey sweet. The Latin word comes from mel, which comes from mel, meaning honey, sweetness, pleasant thing, and the suffix itis, whose meaning is the same as that of the English suffix ite. It was Thomas Willis who, in 1675, added mellitus to the word diabetes as a designation for the disease when he noticed the urine of a person with diabetes had sweet taste glycosuria. This sweet taste had been noticed in urine by the ancient Greeks, Chinese, Egyptians, Indians, and Persians. What is diabetes? Diabetes mellitus, generally known as diabetes, is a group of metabolic disorders distinguished by a high blood sugar level hyperglycemia over a prolonged period. Symptoms usually include frequent urination, increased thirst, and increased appetite. If left untreated, diabetes can cause many health difficulties. Critical complications can include diabetic ketoacidosis, hyperosmolar hyperglycemic state, or death. Serious long-term complications include cardiovascular disease, stroke, chronic kidney disease, foot ulcers, damage to the nerves, damage to the eyes, and mental impairment. Diabetes is triggered by either the pancreas not producing enough insulin or the body cells not responding correctly to the insulin produced. Insulin is a hormone that is responsible for helping glucose from food get into cells to be used for energy. There are three main types of diabetes mellitus. Type 1 diabetes results from the failure of the pancreas to produce enough insulin due to the loss of beta cells. This form was previously referred to as insulin-dependent diabetes mellitus or juvenile diabetes. An autoimmune response causes the loss of beta cells. The cause of this autoimmune response is unknown. Although type 1 diabetes usually appears during childhood or adolescence, it can also develop in adult. Type 2 diabetes begins with insulin resistance, a condition in which cells fail to respond to insulin appropriately. As the disease progresses, a lack of insulin may also develop. This form was previously referred to as non-insulin-dependent diabetes mellitus or adult-onset diabetes. Type 2 diabetes is more common in older adults, but a significant increase in obesity among children has led to more cases of type 2 diabetes in younger people. The most common cause is a combination of excessive body weight and insufficient exercise. Gestational diabetes is the third main form and happens when pregnant women without a prior history of diabetes generate high blood sugar levels. In women with gestational diabetes, blood sugar usually returns to normal soon after delivery. However, there is a higher risk of having type 2 diabetes if you have had gestational diabetes. Patients must manage type 1 diabetes with insulin injections. Prevention and treatment of type 2 diabetes involve maintaining a healthy diet, regular physical exercise, an average body weight, avoiding the use of tobacco. Type 2 diabetes may be treated with oral antidiabetic medications, with or without insulin. Control of blood pressure and maintaining proper foot and eye care are essential for people with the disease. Insulin and some oral medications can cause low blood sugar hypoglycemia. Weight loss surgery for obesity is sometimes an effective measure for those with type 2 diabetes. Gestational diabetes usually resolves after the birth of the baby. As of 2019, an estimated 463 million people had diabetes, 8.8% of the adult population, with type 2 diabetes making up about 90% of the cases. Rates are similar in women and men. Trends suggest that rates will continue to rise. Diabetes at least doubles a person's risk of early death. In 2019, diabetes resulted in approximately 4.2 million deaths. It is the seventh leading cause of death globally. Researchers estimated the global economic cost of diabetes-related health expenditure in 2017 at $727 billion. In the United States, diabetes cost nearly $327 billion in 2017. Average medical expenses among people with diabetes are about 2.3 times higher. We'll delve further into the various types of diabetes a little later on. Signs and symptoms. The classic symptoms of untreated diabetes are unintended weight loss, polyuria, increased urination, polydipsia, increased thirst, polyphagia, and increased hunger. Symptoms may develop rapidly in weeks or months in type 1 diabetes, while they usually develop much more slowly and may be subtle or absent in type 2 diabetes. Several other signs and symptoms can mark the onset of diabetes, although they are not specific to the disease. In addition to the known symptoms include blurred vision, headache, fatigue, slow healing of cuts, and itchy skin. Prolonged high blood glucose can cause glucose absorption in the eye's lens, which leads to changes in its shape, resulting in vision changes. Long-term vision loss can also be caused by diabetic retinopathy. Several skin rashes in diabetes are collectively known as diabetic dermatomes. Diabetic emergencies. People with diabetes, usually but not exclusively in type 1 diabetes, may also experience diabetic ketoacidosis DKA, a metabolic disturbance characterized by nausea, vomiting, and abdominal pain, the smell of acetone on the breath, deep breathing known as Kussmaul breathing, and in severe cases, a decreased level of consciousness. DK requires emergency treatment in the hospital. A rarer but more dangerous condition is hypersmolar hyperglycemic state HHS, which is more common in type 2 diabetes and is mainly the result of dehydration caused by high blood sugars. Treatment-related low blood sugar hypoglycemia is common in people with type 1 and type 2 diabetes, depending on the medication being used. Most cases are mild and are not considered medical emergencies. Effects can range from feelings of unease, sweating, trembling, and increased appetite in mild cases to more severe effects such as confusion, changes in behavior such as aggressiveness, seizures, unconsciousness, and rarely permanent brain damage or death in extreme cases. Rapid breathing, sweating, cold, and pale skin are characteristic of low blood sugar but are not definitive. Mild to moderate cases are self-treated by eating or drinking something high in rapidly absorbed carbohydrates. Severe cases can lead to unconsciousness and must be treated with intravenous glucose or injections with glucagon. Complications. All forms of diabetes increase the risk of long-term complications. These typically develop after 10 to 20 years, but may be the first symptom in those who have otherwise not received a diagnosis. The major long-term complications relate to damage to blood vessels. Diabetes doubles the risk of cardiovascular disease, and about 75% of deaths in people with diabetes are due to coronary artery disease. Other macrovascular disorders include stroke and peripheral artery disease. These complications are also a strong risk factor for severe COVID-19 illness. The primary complications of diabetes due to damage to small blood vessels include damage to the eyes, kidneys, and nerves. Damage to the eyes, known as diabetic retinopathy, is caused by damage to the blood vessels in the eye's retina and can result in gradual vision loss and eventual blindness. Diabetes also increases the risk of having glaucoma, cataracts, and other eye problems. It is recommended that people with diabetes visit an eye doctor once a year. Damage to the kidneys, known as diabetic nephropathy, can lead to tissue scarring, urine protein loss, and eventually chronic kidney disease, sometimes requiring dialysis or kidney transplantation. Damage to the body's nerves, known as diabetic neuropathy, is the most common complication of diabetes. The symptoms can include numbness, tingling, pseudomotor dysfunction, pain, and altered pain sensation, which can damage the skin. Diabetes-related foot problems, such as diabetic foot ulcers, may emerge and can be challenging to treat, occasionally requiring amputation. Additionally, proximal diabetic neuropathy causes painful muscle atrophy and weakness. There is a link between cognitive deficit and diabetes. Compared to those without diabetes, those with the disease have a 1.2 to the 1.5-fold greater rate of decline in cognitive function. Having diabetes, especially when on insulin, increases the risk of falls in older people. Causes. Diabetes mellitus is classified into 6 categories: type 1 diabetes, type 2 diabetes, hybrid forms of diabetes, hyperglycemia first detected during pregnancy, unclassified diabetes, and other specific types. Hybrid forms of diabetes include slowly evolving, immune-mediated diabetes in adults and ketosis-prone type 2 diabetes. Hyperglycemia first detected during pregnancy has gestational diabetes mellitus and diabetes mellitus in pregnancy type 1 or type 2 diabetes first diagnosed during pregnancy. The other specific types are a collection of a few dozen individual causes. Diabetes is a more variable disease than once thought, and people may have combinations of forms. The term diabetes without qualification refers to diabetes mellitus. Type 1. Type 1 diabetes is characterized by the loss of the insulin-producing beta cells of the pancreatic islets, leading to insulin deficiency. This type can be further classified as immune-mediated or idiopathic. The majority of type 1 diabetes is of an immune-mediated nature, in which a T-cell-mediated autoimmune attack leads to the loss of beta cells and thus insulin. It causes approximately 10% of diabetes mellitus cases in North America and Europe. Most affected people are otherwise healthy and of a healthy weight when onset occurs. Sensitivity and responsiveness to insulin are usually normal, especially in the early stages. Although it has been called juvenile diabetes, due to the frequent onset in children, most individuals living with type 1 diabetes are now adults. Brittle diabetes, also known as unstable diabetes or labile diabetes, is a term that was traditionally used to describe the dramatic and recurrent swings in glucose levels, often occurring for no apparent reason in insulin-dependent diabetes. This term, however, has no biological basis and should not be used. Still, type 1 diabetes can be accompanied by irregular and unpredictable high blood sugar levels and the potential for diabetic ketoacidosis or severe low blood sugar levels. Other complications include an impaired counterregulatory response to low blood sugar, infection, gastroparesis, erratic absorption of dietary carbohydrates, and endocrinopathies. These phenomena are believed to occur no more frequently than in 1 to 2% of persons with type 1 diabetes. Type 1 diabetes is partly inherited with multiple genes, including specific HL genotypes, known to influence the risk of diabetes. In genetically susceptible people, the onset of diabetes can be triggered by one or more environmental factors, such as a viral infection or diet. Several viruses have been implicated, but to date, there is no stringent evidence to support this hypothesis in humans. Among dietary factors, data suggests that gliadin, a protein present in gluten, may play a role in developing type 1 diabetes, but the mechanism is not fully understood. Type 1 diabetes can occur at any age, and a significant proportion is diagnosed during adulthood. Latent autoimmune diabetes of adults, LAD, is the diagnostic term applied when type 1 diabetes develops in adults. It has a slower onset than the same condition in children. Given this difference, some use the unofficial term type 1.5 diabetes for this condition. Adults with LAD are frequently initially misdiagnosed as having type 2 diabetes based on age rather than a cause. Type 2. Type 2 diabetes is characterized by insulin resistance, which may be combined with relatively reduced insulin secretion. The defective responsiveness of body tissues to insulin involves the insulin receptor. However, the specific defects are not known. Diabetes mellitus cases due to a known defect are classified separately. Type 2 diabetes is the most common type of diabetes mellitus. Many people with type 2 diabetes have evidence of prediabetes, impaired fasting glucose, and impaired glucose tolerance before meeting the criteria for type 2 diabetes. The progression of prediabetes to avert type 2 diabetes can be slowed or reversed by lifestyle changes or medications that improve insulin sensitivity or reduce the liver's glucose production. Type 2 diabetes is primarily due to lifestyle factors and genetics. Several lifestyle factors are essential to developing type 2 diabetes, including obesity, defined by a body mass index of over 30, lack of physical activity, poor diet, stress, and urbanization. Excess body fat is associated with 30% of cases in people of Chinese and Japanese descent, 60 to 8% of cases in those of European and African descent, and 100% of Pima Indians and Pacific Islanders. Even those not obese may have a high waist-hip ratio. Dietary factors such as sugar-sweetened drinks are associated with an increased risk. The type of fats in the diet is also essential, with saturated fat and trans fats increasing the risk and polyunsaturated and monounsaturated fat decreasing the risk. Eating white rice excessively may increase the risk of diabetes. especially in Chinese and Japanese people. Lack of physical activity may increase the risk of diabetes in some people. Adverse childhood experiences, including abuse, neglect, and household difficulties, increase the likelihood of type 2 diabetes later in life by 32%, with neglect having the most substantial effect. Antipsychotic medication side effects, specifically metabolic abnormalities, dyslipidemia, weight gain, and unhealthy lifestyles, including poor diet and decreased physical activity, are potential risk factors. Gestational diabetes. Gestational diabetes resembles type 2 diabetes in several respects, involving a combination of relatively inadequate insulin secretion and responsiveness. It occurs in about 2 to 10% of all pregnancies and may improve or disappear after delivery. It is recommended that all pregnant women get tested starting around 24 to 28 weeks gestation. It is most often diagnosed in the second or third trimester because of the increase in insulin antagonist hormone levels that occurs at this time. However, after pregnancy, approximately 5 to 10% of women with gestational diabetes have another form of diabetes, most commonly type 2. Gestational diabetes is fully treatable but requires careful medical supervision throughout the pregnancy. Management may include dietary changes and blood glucose monitoring, and in some cases, patients may require insulin. Though it may be transient, untreated gestational diabetes can damage the health of the fetus or mother. Risks to the baby include macrosomia, high birth weight, congenital heart, central nervous system abnormalities, and skeletal muscle malformations. Increased insulin levels in a fetus's blood may inhibit fetal surfactant production and cause infant respiratory distress syndrome. A high blood bilirubin level may result from red blood cell destruction. In severe cases, perinatal death may occur, most commonly due to poor placental perfusion due to vascular impairment. Labor induction may be indicated with decreased placental function. A doctor may perform a cesarean section with marked fetal distress or an increased risk of injury associated with macrosomia, such as shoulder dystocia. Other types: maturity onset diabetes of the young MODY is a rare autosomal dominant inherited form of diabetes due to one of several single gene mutations causing defects in insulin production. It is significantly less common than the three main types, constituting 1 to 2% of all cases. The name of this disease refers to early hypotheses as to its nature. Due to a defective gene, this disease varies in age at presentation and severity according to the specific gene defect. Thus, at least 13 subtypes of MODY exist. People with MODY often can control it without using insulin. Some cases of diabetes are caused by the body's tissue receptors not responding to insulin even when insulin levels are normal, which is what separates it from type 2 diabetes. This form is very uncommon. Genetic mutations, autosomal or mitochondrial, can lead to defects in beta cell function. Patients may have genetically determined abnormal insulin action in some cases. Any disease that causes extensive damage to the pancreas may lead to diabetes, for example, chronic pancreatitis and cystic fibrosis. Conditions associated with excessive secretion of insulin antagonistic hormones can cause diabetes, typically resolved once the hormone excess is removed. Many drugs impair insulin secretion, and some toxins damage pancreatic beta cells, whereas others increase insulin resistance, especially glucocorticoids, which can provoke steroid diabetes. The ICD-10-1992 diagnostic entity, malnutrition-related diabetes mellitus ICD-10 code E12, was deprecated by the World Health Organization, who, when the organization introduced the current taxonomy in 1999. Pathophysiology. Insulin is the principal hormone that regulates glucose uptake from the blood into most body cells, especially the liver, adipose tissue, and muscle, except smooth muscle, in which insulin acts via the IGF-1. Therefore, insulin deficiency, or the insensitivity of its receptors, plays a central role in all forms of diabetes mellitus. The body obtains glucose from three primary sources: the intestinal absorption of food, the breakdown of glycogen glycogenolysis, the storage form of glucose found in the liver, gluconeogenesis, the generation of glucose from non-carbohydrate substrates in the body. Insulin plays a critical role in regulating glucose levels in the body. Insulin can inhibit the breakdown of glycogen or the process of gluconeogenesis. It can stimulate the transport of glucose into fat and muscle cells and enable glucose storage in the form of glycogen. Insulin is released into the blood by beta cells found in the islets of Langerhans in the pancreas in response to rising blood glucose levels, typically after eating. Insulin is used by about 2/3 of the body's cells to absorb glucose from the blood for use as fuel, for conversion to other needed molecules or storage. Lower glucose levels result in decreased insulin release from the beta cells and the breakdown of glycogen to glucose. This process is mainly controlled by the hormone glucagon, which acts oppositely to insulin. If the amount of insulin available is insufficient, if cells respond poorly to insulin resistance, or if the insulin itself is defective, glucose is not absorbed correctly by the body cells that require it and is not stored appropriately in the liver and muscles. The net effect is persistently high levels of blood glucose, poor protein synthesis, and other metabolic derangements, such as metabolic acidosis in cases of complete insulin deficiency. When the glucose concentration in the blood remains high over time, the kidneys reach a threshold of reabsorption, and the body excretes glucose in the urine glycosuria. This increases the osmotic pressure of the urine and inhibits the reabsorption of water by the kidney, resulting in increased urine production polyuria and increased fluid loss. Lost blood volume is replaced osmotically from water in body cells and other body compartments, causing dehydration and increased thirst polydipsia. In addition, intracellular glucose deficiency stimulates appetite, leading to excessive food intake polyphagia. Prevention. There is no known preventive measure for type 1 diabetes. Type 2 diabetes, which accounts for 85 to 90% of all cases worldwide, can often be prevented or delayed by maintaining an average body weight, engaging in physical activity, and eating a healthy diet. Higher levels of physical activity for more than 90 minutes per day reduce the risk of diabetes by 28%. Dietary changes known to be effective in helping to prevent diabetes include maintaining a diet rich in whole grains and fiber and choosing good fats, such as the polyunsaturated fats found in nuts, vegetable oils, and fish. Limiting sugary beverages and eating less red meat and other sources of saturated fat can also help prevent diabetes. Tobacco smoking is also associated with an increased risk of diabetes and its complications, so smoking cessation can be an important preventive measure. The relationship between type 2 diabetes and the main modifiable risk factors of excess weight, unhealthy diet, physical inactivity, and tobacco use is similar in all world regions. There is growing evidence that the underlying determinants of diabetes reflect the major forces driving social, economic, and cultural change: globalization, urbanization, population aging, and the general health policy environment. Management. Diabetes management concentrates on keeping blood sugar levels close to normal without causing low blood sugar. Patients can usually accomplish this with dietary changes, exercise, weight loss, appropriate medications, insulin, and oral medications. Learning about the disease and actively participating in the treatment is vital, since complications are far less common and less severe in people with well-managed blood sugar levels. Per the American College of Physicians, the goal of treatment is an HbA1c level of 7 to 8%. Attention is also paid to other health problems that may accelerate the adverse effects of diabetes. These include smoking, high blood pressure, metabolic syndrome, obesity, and lack of regular exercise. Specialized footwear is widely used to reduce the risk of ulcers in at-risk diabetic feet, although evidence for the efficacy remains equivocal. The principles of managing diabetes may be similar across the general population with diabetes. However, some considerations may need to be addressed when tailoring intervention. Considering those with severe mental illness, the efficacy of type 2 diabetes self-management interventions is still poorly explored, with insufficient scientific evidence to show whether these interventions have similar results to those observed in the general population. Lifestyle. People with diabetes can benefit from education about the disease and treatment, dietary changes, and exercise to keep both short-term and long-term blood glucose levels within acceptable bounds. In addition, given the associated higher risks of cardiovascular disease, lifestyle modifications are recommended to control blood pressure. Weight loss can prevent progression from prediabetes to diabetes type 2, decrease the risk of cardiovascular disease, or result in partial remission in people with diabetes. No single dietary pattern is best for all people with diabetes. Healthy nutritional habits, such as the Mediterranean diet, low-carbohydrate diet, or DASH diet, are often recommended, although evidence does not support one over the others. According to the ADA, reducing overall carbohydrate intake for individuals with diabetes has demonstrated the most evidence for improving glycemia, and for individuals with type 2 diabetes who cannot meet the glycemic targets, or where reducing anti-glycemic medications is a priority, low or very low carbohydrate diets are a viable approach. Any diet that achieves weight loss for overweight people with type 2 diabetes is effective for overweight people. Medications. Most medications used to treat diabetes act by lowering blood sugar levels through different mechanisms. There is broad consensus that when people with diabetes maintain tight glucose control, keeping the glucose levels in their blood within normal ranges, they experience fewer complications, such as kidney problems or eye problems. There is, however, a debate as to whether this is appropriate and cost-effective for people later in life, in whom the risk of hypoglycemia may be more significant. There are several different classes of antidiabetic medications. Type 1 diabetes requires treatment with insulin, ideally using a basal bolus regimen that most closely matches regular insulin release, long-acting insulin for the basal rate, and short-acting insulin with meals. Type 2 diabetes is generally treated with medication taken by mouth, although some eventually require injectable treatment with insulin or GLP-1 agonists. Metformin is generally recommended as a first-line treatment for type 2 diabetes, as there is good evidence that it decreases mortality. It works by reducing the liver's production of glucose. Several other drugs, mostly given by mouth, may also lower blood sugar in type 2 diabetes. These include agents that increase insulin release sulfonylureas. These agents decrease the absorption of sugar from the intestines acarbose. These agents inhibit the enzyme dipeptide L-peptidase 4-DPP4 that inactivates incretins such as GLP-1 and G-ip-sitagliptin, which make the body more sensitive to insulin thiazolidine and agents that increase the excretion of glucose in the urine SGLT2 inhibitors. When insulin is used in type 2 diabetes, a long-acting formulation is usually added initially while continuing oral medications. Doses of insulin are then increased until glucose targets are reached. Blood pressure lowering. Cardiovascular disease is a severe complication associated with diabetes, and many international guidelines recommend blood pressure treatment targets that are lower than 140/90 millimeters of mercury for people with diabetes. However, there is only limited evidence regarding what the lower targets should be. A 2016 systematic review found potential harm to treating targets lower than 140 millimeters of mercury, and a subsequent systematic review in 2019 found no evidence of additional benefit from blood pressure lowering to between 130 to 140 millimeters of mercury. However, there was an increased risk of adverse events. 2015 American Diabetes Association recommendations are that people with diabetes and albuminuria should receive an inhibitor of the renin-angiotensin system to reduce the risks of progression to end-stage renal disease, cardiovascular events, and death. There is some evidence that angiotensin-converting enzyme inhibitors ACE are superior to other inhibitors of the renin-angiotensin system, such as angiotensin receptor blockers RBS or alloskyrine in preventing cardiovascular disease. However, a more recent review found similar effects of ACE and RBS on primary cardiovascular and renal outcomes. No evidence combining ACE and RBS provides additional benefits. Aspirin. The use of aspirin to prevent cardiovascular disease in diabetes is controversial. Some recommend aspirin for people at high risk of cardiovascular disease. However, routine use of aspirin has not been found to improve outcomes in uncomplicated diabetes. 2015 American Diabetes Association recommendations for aspirin use based on expert consensus or clinical experience are that low-dose aspirin use is reasonable in adults with diabetes who are at intermediate risk of cardiovascular disease, 10-year cardiovascular disease risk, 5 to 10%. National guidelines for England and Wales by the National Institute for Health and Care Excellence, NICE, recommend against aspirin in people with type 1 or type 2 diabetes who do not have confirmed cardiovascular disease. Surgery. Weight loss surgery in those with obesity and type 2 diabetes is often an effective measure. Many can maintain normal blood sugar levels with little or no medications following surgery, and long-term mortality is decreased. There is, however, a short-term mortality risk of less than 1% from the surgery. The body mass index cutoffs for when surgery is appropriate are not yet clear. It is recommended that this option be considered for those who cannot get both their weight and blood sugar under control. A pancreas transplant is occasionally considered for people with type 1 diabetes who have severe disease complications, including end-stage kidney disease requiring kidney transplantation. Self-management and support. In countries using a general practitioner system, such as the United Kingdom, care may occur mainly outside hospitals, with hospital-based specialist care used only in case of complications, difficult blood sugar control, or research projects. General practitioners and specialists share care in a team approach in other circumstances. Home telehealth support can be an effective management technique. Using technology to deliver educational programs for adults with type 2 diabetes includes computer-based self-management interventions to collect tailored responses to facilitate self-management. There is no adequate evidence to support effects on cholesterol, blood pressure, behavioral change, such as physical activity levels and dietary, depression, weight, and health-related quality of life, or other biological, cognitive, or emotional outcomes. Epidemiology. In 2017, 425 million people had diabetes worldwide, up from an estimated 382 million people in 2013 and 108 million in 1980. Accounting for the shifting age structure of the global population, the prevalence of diabetes is 8.8% among adults, nearly double the rate of 4.7 in 1980. Type 2 makes up about 90% of the cases. Some data indicate rates are roughly equal in women and men. Still, male excess in diabetes has been found in many populations with higher type 2 incidence, possibly due to sex-related differences in insulin sensitivity, consequences of obesity and regional body fat deposition, and other contributing factors such as high blood pressure and tobacco smoking, and alcohol intake. The WHO estimates that diabetes resulted in 1.5 million deaths in 2012, making it the 8th leading cause of death. However, another 2.2 million deaths worldwide were attributable to high blood glucose and the increased risks of cardiovascular disease and other associated complications, such as kidney failure, which often lead to premature death and are usually listed as the underlying cause on death certificates rather than diabetes. For example, in 2017, the International Diabetes Federation (IDF) estimated that diabetes resulted in 4 million deaths worldwide, using modeling to count the total number of deaths that could be directly or indirectly attributed to diabetes. Diabetes occurs throughout the world, but is more common, primarily type 2, in more developed countries. However, the most significant increase in rates has been seen in low and middle-income countries, where more than 80% of diabetic deaths occur. The fastest prevalence increase is expected to occur in Asia and Africa, where most people with diabetes will probably live in 2030. The increase in rates in developing countries follows the trend of urbanization and lifestyle changes, including increasingly sedentary lifestyles, less physically demanding work, and the global nutrition transition, marked by increased intake of foods that are high energy dense but nutrient poor, often high in sugar and saturated fats, sometimes referred to as the Western-style diet. The global number of diabetes cases might increase by 48% between 2017 and 2045. Society and culture. The 1989 St. Vincent Declaration resulted from international efforts to improve the care accorded to those with diabetes. Doing so is essential in terms of quality of life and life expectancy, and economically, expenses due to diabetes are a significant drain on health and productivity-related resources for healthcare systems and governments. Several countries established more and less successful national diabetes programs to improve the treatment of the disease. People with diabetes who have neuropathic symptoms, such as numbness or tingling in feet or hands, are twice as likely to be unemployed as those without the symptoms. In 2010, diabetes-related emergency room (ER) visit rates in the United States were higher among people from the lowest income communities, 526 per 10,000 population, than from the highest income communities, 236 per 10,000 population. Approximately 9.4% of diabetes-related ER visits were for the uninsured. The term type 1 diabetes has replaced several former terms, including childhood-onset diabetes, juvenile diabetes, and insulin-dependent diabetes mellitus. Likewise, the term type 2 diabetes has replaced several former terms, including adult-onset diabetes, obesity-related diabetes, and non-insulin-dependent diabetes mellitus. Beyond these two types, there is no agreed-upon standard nomenclature. Diabetes mellitus is also occasionally known as sugar diabetes to differentiate it from diabetes insipidus. Can diabetes occur in animals? In animals, diabetes is most commonly encountered in dogs and cats. Middle-aged animals are most commonly affected. According to some sources, female dogs are twice as likely to be affected as males, while male cats are more prone than females. In both species, all breeds may be affected, but some small dog breeds are particularly likely to develop diabetes, such as miniature poodles. Feline diabetes is strikingly similar to human type 2 diabetes. The Burmese, Russian Blue, Abyssinian, and Norwegian forest cat breeds are at higher risk than other breeds. Overweight cats are also at higher risk. The symptoms may relate to fluid loss and polyuria, but the course may also be insidious. Diabetic animals are more prone to infections. The long-term complications recognized in humans are much rarer in animals. The principles of weight loss treatment, oral antidiabetics, subcutaneous insulin, and management of emergencies like ketoacidosis are similar to those in humans. We hope that has shed some much-needed light on diabetes for you. Join us soon for another episode of Healthpedia.tv. Until then, stay active.